Hi everyone, can you hear me? Okay, great. Do we think any more people are coming? Or is it normally around this number? All right. How have you all been doing? Are you still, when are your exams again? 24th of August. And have you just been, are you all revising a bit here and there and doing a bit of relaxing? Or it's been quite a long time? Okay, so we had the original surgical series and there's quite a few more presentations that I didn't get to do in the end. So I'm going to continue along that line. So the next one for this week is nausea and vomiting in surgery. And I think that by now, because I've been away for 6 or 7 weeks now, you probably have all done quite a lot of work at home and bits here and there. So you probably all know your stuff. So I think it's more an opportunity for you to practice what you know. Okay, just admit a few more people and then we'll start. So I'm hoping it's going to be quite interactive. So make sure you message on the chat. And if any questions during the thing, we can chat about them. There's not too many people. So 14 people today for the talk. So if you want to message, bring something up, we can have a talk about it and clear anything up. So feel free to do that. Okay, so I think I'm going to start now. So as I said, this week is going to be about nausea and vomiting in surgery. So we'll start off as always, usually with a case to go through this section. And we'll keep it quite simple. So Mr. Smith is a 53-year-old male. He arrives into A&E complaining of repeated vomiting. So it's quite a broad topic, vomiting. What kind of problems can we have that cause vomiting? Just throw a few in the chat. Tear? Yeah, gastritis, obstruction. Good, yeah. So we've all kind of gone for GI things. What about outside the world of GI? Yeah, infection, MI, good. Yeah, corona might make you feel like you want to vomit. But it's such a vast field. Yeah, electrolyte imbalances. So as you see there, renal colic, yeah, so it doesn't have to be GI problems. We're going to focus mostly on GI and the surgical route this week. But I think it's important to start off with the broader knowledge of what nausea and vomiting is and how we can split it into categories. So I think you've probably all done this in palliative, which is part of the physiology of mesis. So basically, vomiting and the urge to vomit comes from stimulation of the vomiting center in the medulla. You've got multiple mechanisms of how you can stimulate this vomiting center. So you can start with, can you see my cursor? It's been so long, I've forgotten if it works or not. Yeah, thanks. So on this side, you have the chemoreceptor part, so the dopamine, 5-HT part. So you've got a chemoreceptor, which can stimulate the vomiting center. You've got central cerebral cortex, so things like thought, sight, and smell, so food you don't like, makes you feel sick. And then you've got the pharynx and the gut system, so from the vagal nerve, you have stimulation, which leads to 5-HT3 receptors. And this is probably what we're going to focus on more today, this 5-HT3 receptor, so vagal stimulation, which leads to vomiting center stimulation. And then also you have the vestibular nuclei, so like parts of the ear which cause motion sickness, which are normally caused by like histamine signals. So we've got 4 kind of mechanisms of how we stimulate the vomiting center. So we can kind of put our problems into 4 sections. So we have this on the left, we've got the problems with the ear, so vertigo-based stimulation of nausea, so Meniere's, benign paroxysmal vertigo, motion sickness. And as we discussed, someone said electrolyte imbalances, where there's chemicals in the blood, so hormones, electrolytes, toxins, which cause this chemical receptors, the dopamine part, which is also like opioids, that kind of stuff. Then you've got the central brain kind of parts. So this is the cerebral cortex part with the raised ICP, meningitis, encephalitis. And then what we're going to focus on, so the vagal stimulation, the 5-HT3 part, serotonin, the GI obstruction, GI infection, inflammation of the diaphragm, and inflammation of like the liver and other parts of the GI system. So we split it up into 4 sections. So we can kind of go about now how we can split our patients' problems into these 4 sections. So we're going to have to take a history from this patient. They're coming with a very vague symptom of vomit. So the first most important thing is the vomit itself. So in an Oski station, you can probably spend about a minute's worth on the contents of the vomit. You can ask multiple questions, but I think the most important ones are the contents. So we split it into things like the coffee ground stains, or is it just food being regurgitated, or is it blood? It's important distinguishing factors. The timing, so this can also be associated with eating, but timing is after an event as well. So did it come after a head injury? So how frequently does it occur? And association with eating, most commonly in problems such as like gastroenteritis or problems such as like obstruction. With timing as well, you can have things like not only in the GI system, so if we go back to the cranial section, so if it's cerebral, timing in such as like increased pressure in the head more commonly affects people in the morning. And then also in the broader spectrum, things like pregnancy, timing can be such a broad spectrum in Oski. Okay, and further questions. So most commonly in the GI system, you get associated pain. So go through our Socrates as always. And associated symptoms are really going to help us to distinguish what's causing nausea. So fever, headache, visual disturbances, and vertigo are basically going to send us down one of those 4 tracks. And then as always, we have to talk about bowel movements. And we're going to talk about that quite a lot today in absolute constipation or diarrhea. It's going to be either obstruction or probably a gastroinfection. And then in the real world, it's going to be probably caused a lot by things like alcohol, medications, chemotherapy. They're going to cause quite a lot of nausea within hospitals. We tend to cause a lot more nausea than people come in with. And then social factors. This and liver disease are similar kind of things you want to talk about, like close contacts, foreign travel, unusual meals, things like that. Okay. So as we said before, you can kind of use this associated symptoms to split it into the 4 sections. Well, there's 5 in this case, but one of them is none of. So with the associated symptoms, we have nausea and vomiting. If we have an associated symptom of abdo pain, we can kind of pick these differentials on the left-hand side here. And then we can kind of split them into 2 as well, with fever and no fever. So if the patient comes in with abdo pain and nausea, vomiting, with a fever, you're kind of thinking infective things, really. So hepatobiliary infections, appendicitis, gastroinfections. And without a fever, you're looking at metabolic problems, toxins, like vascular problems, renal stones. This will also go with like obstruction, would also go in this section. With a headache, you kind of think in the intracranial pathology, but it could kind of overlap with vertigo. And vertigo, you're kind of going to go straight down to that vestibular system. And if you're finding that the patient's got nausea and vomiting straight after food or increases after food, it's most likely it's going to be an obstructive problem. You can also find sections that don't fit into any of these. So patients do have psychosomatic pathology, which leads them to feel nausea and vomiting. But these are you can have to exclude the other things first. And then systemic metabolic problems. So you might get abdo pain with some metabolic problems, but you might not. Things like uremia and hypothyroid problems. So this is quite useful to kind of box differentials into their associated symptoms. And it's usually quite helpful in questions. Usually they give you quite a quite useful associated symptom. And it's kind of like pulls you down one of these tracks. Okay, any questions so far? Okay. So serious symptoms. So most important usually in the OSCE world, really, but also as a student, but also in the real world. So the serious symptoms, it's kind of those red flag symptoms that you're going to have to try and elicit a yes or no question for, really, just to make sure you've not got serious pathology. So on these, we're going to do like a quick little quiz, what we think it might be leading to. So in this first patient, you've got a young, thin patient, and they've got a little bit of reduced GCS. What kind of problems might be causing nausea and vomiting in this patient? What might it be? Yeah, DKA, really good. Well, really. So as we said, metabolic problems can cause nausea and vomiting. And this is one of the most important things to exclude in young people. Fecal vomiting, what kind of problems would lead to fecal vomiting? Yeah, so any kind of absolute obstruction, really. So you've got tumor obstruction, volvulus, anything that's an absolute obstruction, and it's going to be further down the gastro system, maybe in the large bowel. We have stiff neck and photophobia. This one should be, yeah, nice one, Katrin. Meningitis, really important. And then early morning vomiting, headache, worse on lying down or bending. Kind of might give this one away a little bit earlier. Yeah, raised intracranial pressure, nice. So we have a patient who's quite emotionless, or quite a thin abdomen and no bowel sounds when you auscultate. This is really important to exclude. It can it's mainly probably a side effect of a cause of obstruction. Any takers? Yeah, Olivia, perforation, great. So we need to exclude peritonitis. And the last one, someone said it earlier or in the chat, it's the central chest pain, pale and clammy. Yeah, MI, nice. But it's important to recognize that if you've got a patient who is in the older age group, who's come with this nausea and vomiting, you need to exclude MI from these patients, really. So that includes taking a history, and also if you're going to have an older patient in A&E, they're going to get an ECG. You're going to do drops on them, really, just to make sure. Okay, so now we get a bit more history from Mr. Smith. We find out he's been vomiting for a couple of hours after dinner 2 nights ago. And the vomit contains digestive food, but it's not associated with meals. Mr. Smith struggled to eat during the pain. The pain has been described as crampy. And it's vaguely around the umbilical area, but it's not really well localized. He gets a little bit of relief from vomiting. The pain is sort of 7 or 8 out of 10. He's kind of tired, but he's got no night sweat. But he hasn't really eaten much in the past 36 hours. And he has to open his bowels yesterday morning. getting rid of that today. But his past medical history, he's had an appendicectomy and migraines, and he takes sumatriptan. He's got no allergies, non-smoker, but he drinks a bottle. So hard to get this chat out of the way. Drinks a bottle of wine a week at most, and he denies taking recreational drugs. What kind of differentials now do we think about? He's kind of give us a bit more information in this history. Yeah, it goes straight for the adhesions. Nice. I assume that's from the appendicectomy. Do we have any other ones? Gastroenteritis, potentially, yeah. We haven't got any vitals yet, so it could be. Anything else? Renal stones could be, yeah, quite painful. Yeah, could be a migraine. Yeah, could easily be a migraine. It's lasted quite a long time, but it could easily be a migraine. It's important not to ignore that. Well, are there any iatrogenic things that we might be causing his nausea and vomiting with? A bit of pharmacology. Yeah, so drug effect of sumatriptan. So the mechanism of sumatriptan is a 5-HT agonist, which can cause nausea and vomiting through that vagal system. So it's always important to make sure we're not causing the problems. But I think he's been taking it for a long while in this case. But if he's changed his like dosage recently or anything's changed, it's important to exclude that. So we've discussed a few things it could be. Some obstructive problems like adhesions, some problems like migraine or side effects. So we're still here a little bit unsure what it could be. So now we should really examine the patient. So what kind of things are we looking for in a general GI? Let's say an abdominal examination. What kind of things are you looking for in this patient if you think he's got an obstructive picture? Scars, yeah. You're going to see a scar from his appendicectomy. Great. It's always quite easy to overlook these things. You expect a scar, so you forget to see it when you see it when it's on there. Tenderness and guarding, yeah. Distension, yeah. The 5 Fs, yeah. Palpating for any masses. Absent bowel sounds, yeah. Great. Yeah, potentially signs of liver pathology. You might do. Yeah, large amounts of weight loss. Yeah, really important. Really important to exclude that. Especially he's been feeling quite malaised. We never really mentioned that it could be cancer. Signs of dehydration. Yeah, this patient's been vomiting. Yeah, I think they're all really good points. I think it's really good that you all looked at not just specific things to the abdomen, especially like things like dehydration, things that are quite easy, simple and quite easy to overlook. I'm sure you've all been practicing your abdominal examinations at home. Do you have OSCEs in October, November? I can't remember. November, I think. Yeah, I think I saw the timetable come through. Do you have good like practice for that? Like, are you able to practice that at home? Because I can ask Fraser, and we can potentially set up some kind of. Remember the written. Yeah, fair enough. We're just thinking potentially we could do some kind of like video call thing where we can like mark them. Okay, cool. Let's move on. So we've examined the patient now. So Mr. Smith is lying in the bed, but he's in a bit of pain. We've seen that there's no peripheral stigmata of GI disease in this patient. There's no jaundice, but he's got an appendectomy scar, and he's got mild distension of his abdomen. When you palpate it, his abdomen is soft and non-tender on palpation, no masses or organomegaly present. He's got high-pitched tinkling bowel sounds on auscultation. Does this focus our differentials anymore? What do we think now? Have we got a definitive one? Yeah, it's most likely to be an obstruction, and I think it's very easy in when you hear the first introductory section, when you hear he's got an appendectomy scar, to go straight to adhesions, and it probably is that in this patient's case, Mr. Smith. But I think it's really important to go through the systemic history examination anyway, just in case. You have to exclude these important things like his migraine and other aspects. Okay, so what can we investigate for him? So if we're taking blood from him, we're going to be looking for if he's got a gastroenteritic picture. We're going to see high inflammatory markers in that case. For the UNEs, it's basically going to be aimed at for how hypovolemic is the patient. Has he lost a lot of potassium and chloride due to vomiting quite a lot? And how can we treat that? It's going to be aiming for treatment of the vomiting, really. And the LFTs we can take for him to diagnose if he's got any hepatobiliary disease. What are the best biomarkers to test for liver function, which aren't ALP and ALT, if we're looking at some kind of liver disease? This is from one of my other lectures. Yeah, prothrombin, really important. So there's probably three ones that are really important for successful in liver disease. Albumin, yeah, great. Yeah, and bilirubin. So the three most important ones are prothrombin time, or just clotting time in general, albumin and bilirubin. These are more functional aspects of the liver. Okay. What other investigations can we do? So in this patient, we have a male, but it's really important if in a female, the first thing we'll probably do is ask in the history if they're pregnant. And then if they consent for a pregnancy test, it's really important to do one. Toxicology we can do if we suspect that the patient has any overdoses, or we've given them medication. And urinalysis is really important as well, especially if we think it's like a renal colic picture. And it's a quick thing that we can do just to rule out that differential. Really important if the patient's had a head injury. So how many episodes of vomiting do you need to have for us to give you a CT head if you've had a head injury? So it has to be greater than one. So it has to be 2 or more. And then the CT has to take place within an hour of finding that out. So if the patient's had two or more episodes of vomiting after a head injury, you need to give them a CT head within an hour. We can also give patients an MRI if we think it's intracranial. So increased cranial pressure, or there are intracranial pathologies that are causing it. But usually these are more elective. Okay, so imaging, the most important part. So how can we image? What can we image for? So in the abdomen, the only kind of things you're looking for is the supine and abdominal X-ray. So supine X-ray, it's common now for patients only to get a supine X-ray because you don't really need a laid down one for the abdominal X-ray because it shows you the same thing. But for some reason, some people still do both. but I think it's adequate just to do the supine X-ray, because then you can see air under the diaphragm, and it gives you a good picture of the abdomen anyway. You can also have ultrasound, and this is probably most important in things like appendicitis. And this will be the first thing that you can do to rule out appendicitis. It's not used really for ruling in appendicitis, but it's a method of ruling it out. Because if it's clearly not there on the ultrasound, then it's a very high sensitivity to rule it out. But you might need other imaging to diagnose, but it's usually clinical, and it usually be taken straight to theatre. So if you're doing a supine X-ray, you're kind of expecting a bowel perforation where the patient's quite tachycardic, he's got a high fever, and he's got pain and tenderness on the examination. And it's usually quite easy to see. You're looking at the apex of the diaphragm. I don't think I have a picture of this actually. I should have got more pictures on. Okay, what's the do you know what the 3-6-9 rule is for? Yeah, diameters of bowel. So these are maximum limits you really have on X-ray. What's the maximum? What's 3? What's a maximum of 3 centimeters? Small bowel, yeah. And 6. So 6 is large bowel and 9 is cecum. You can get greater distension in the cecum. I think it's important to find that out now. So it's good. Someone else needed to help you out, Danny. You're doing all the work in the chat. Okay. Well, one of the most important things we need to do is if we suspect any kind of obstruction, usually in large bowel obstruction, 90% of obstructions are diagnosed by CT scan. So if you're suspecting a large bowel obstruction, the patient's going to go for a CT normally. And that's helpful in 90% of the cases. But if you suspect a small bowel obstruction, this actually requires a CT through the guidelines. So if you think it's small bowel obstruction, it has to go to CT. And if it's large bowel obstruction, it's usually very helpful to go to CT. So most patients are going to get a CT scan if they have a small or large bowel obstruction. We can always use a barium enema, and this normally is used for like finding out the extent and location of the obstruction. This, in a lot of cases, can be used in locating the tumors, but they will all go to CT scan as well. So it's not used that often. And endoscopy can be used as well. Not only can it be used for imaging, it can also be used for treatment as well, which we'll discuss later on. Okay, so what's the pathology in this radiography? What's distended? Yeah, small bowel, great. Yeah, you can see the valvular conventates there. They go across the whole of the lumen. Got a few more pictures. Okay. Where's the pathology in this one? You can just say what's distended because you can't really see where it's going to be. Yeah, you've got large bowel there. And you can see the haustra, which don't go across all the way. It's usually easier to look if in the left like fossa really, because you can see how distended the rectum is normally. Okay, what pathology we got here? This is classic. So there's going to be quite a lot of obstruction here, but there's a big clinical sign. Yeah, so we've got a volvulus here. Yeah, sigmoid volvulus. So can you see we've got this coffee bean shape here. So you have the the outer rim here. So that'll be the rectum. This will be the sigmoid coming down into the descending colon. You see you got that coffee bean shape. But you can see there's so much distended across here. Right. And this is barium enema. And you'd have this in, so this is the sign you get in barium enema. It's called a bird's beak. You see at the top here. And that's what you get in most complete obstructions, is this bird beak sign. Okay. Right. So what can cause small bowel obstruction? So there's quite a few things, but we're going to get just a couple of simple ones. So you can get ileus, which can occur post-surgical or medication or systemic ileus. And this is just where the small bowel refuses to perform peristalsis. And you can kind of see, if you take a CT, the patient's not going to be any different. It's going to be normal, a small bowel. So how you need to differentiate between these is you need to give this patient a contrast. And in this patient, all the contrast will pass through the bowel as normal because there's no obstruction or any problem. And it'll usually be diagnosed with a history as well. So contrast and history. So you have this post-surgical patient which passes contrast. It's usually ileus. For gastroenteritis, it's normally based on the history and on the patient's vitals, normally with an infected picture and bloods. Appendicitis can be mostly clinical, and as we said, you can take the ultrasound looking for the fecal lift. And then if required, you can do a CT of the patient, but it's never normally, doesn't go that far. For small bowel tumours, this will be CT, and for strangulation of a hernia, it's also CT. And then finally, we discussed adhesions in the actual patient, Mr. Smith. And with all the rest of them, that's CT as well. So it can tell you how important small bowel obstruction CT scans are. Okay. So then large bowel obstruction, they're kind of slightly different, but similar because it's just a tube basically. So anything that stops it. Colorectal malignancy, you're kind of looking at older patients, and it's the history of the like weight loss, reduced bowel motions, and sometimes rectal bleeding that you have. For chronic volvulus, this is more often in like institutionalized patients or those that have a history of mental illness. It can be caused by like laxative abuse or if they've had previous megacolon or abdominal surgery. And this comes on much faster. It's very abrupt and can often perforate quite quickly. For diverticular disease, you're kind of looking at older patients again. And this is a slower picture. The patients normally have, you have that like rabbit dropping stool. It can go on for quite a while. Patients can go in and out of hospital and eventually end up in a bowel obstruction. So they have this tenderness and abdominal pain for quite a long time that like comes and goes. And then benign strictures, it's patients that have had like previous radiotherapy. And the radiotherapy normally is in the sigmoid colon. But in these patients, it's not always complete obstruction. This is where you get kind of a tenesmus picture. So the two kind of things you can see tenesmus in, so this feeling of not passing stool completely, is normally like a rectal or a lower down colorectal cancer, or these benign strictures caused by radiotherapy. It's also important to make sure in benign strictures, if it's in a female, if they've got a history of gynecological disease, because if you're going to treat them, it's going to have a gynecological assistance as well, and quite commonly also renal, because it tends to cause a lot of abdominal havoc everywhere. Okay. So we kind of split these treatments up into complete obstruction and incomplete obstruction. So for small bowel, well, the first and most important part of all these obstructive pictures is the drip and suck. So all these patients need nasogastric decompression and IV fluids. So for patients that have got complete obstruction in the small bowel, they need to go for emergency laparoscopy, really. because most of these patients already have peritonitis, and if you don't treat them straight away from surgery, they're more likely, well, they're going to get peritonitis at some point. And in small bowel obstruction, if you're going to go to surgery, all the patients need prophylaxis for these gram-negative bacteria, especially because if they're going to perforate, you don't want to get peritonitis. And then what you need to do afterwards, once you've had a laparoscopy and gone in, you need to resolve the underlying pathology. So for most of these things, like for appendicectomy, you need a appendicectomy, or if you've got, you can do Ladd's procedure, or for like malrotation or resection or hernia repair. So you just treat the underlying pathology surgically. Okay. And for non-surgical candidates, usually these are patients who are too frail to go for surgery, or on palliative for other reasons. We always need to trip and suck for these patients as well. And we can give them antiemetics such as ondansetron. So ondansetron works by, it's a 5-HT receptor antagonist. So as we said before, the 5-HT stimulation causes this nausea stimulation. We need to antagonize this by providing ondansetron. And also, patients can be given antispasmodics. Most commonly, it's things such as like atropine sulfate. And it's just for patients to not have that pain, really. But the drip and suck actually resolves 1/3, I think it's 1/3 of these obstructions. So drip and suck actually is really helpful, not just symptomatically. And in partial obstruction, the patients, we need to always drip and suck and then treat the underlying cause. So we don't need to go straight in for a laparoscopy in small bowel obstruction if it's partial, because they're not as likely to be peritonitic. So we can do the appropriate elective surgery. You can also do balloon dilation for patients with Crohn's adhesions. You can either do it surgically or you can do it by balloon dilation. And then, as we discussed before, you can do these, provide these enemas. And the provision of gastrographin can actually treat quite a few patients in acute small bowel obstruction if they have adhesions. So not only is it visualizing, it can also treat patients. But if these alternative methods don't work, we need to go in for a laparoscopy. The large bowel treatment is slightly different because the large bowel is a bit stronger than the small bowel. So we don't need as much to treat quickly. So if it's non-perforated, we can give supportive measures for up to 72 hours. And then we can treat within this period. But if it's perforated, we need to do emergency laparotomy. Does everyone mind if I go for a second? I need to go get the door. All right. Sorry. 2 secs. Sorry. Yeah, so for large bowel treatment, we get a bit more time because of how thick the lumen is. And if we're not perforated, we can give supportive measures, 72 hours. We can treat this electively, or we can treat it by the methods. But if it's perforated, we have to do emergency laparotomy. Okay. So for the treatments for specific pathology with non-peritonitis, for sigmoid volvulus, we first of all, we can go with a sigmoidoscopy. And you have a rectal tubing. So this is where you put the sigmoid scope in the rectum. You go up the descending colon, and you place a metal tube in there. And this just re-straightens out the colon. And this stops the need for having to have surgery.
surgery is basically the last choice for most things. But if it doesn't work, you have to leave it in for how long? 24 hours. And if it doesn't work, you go to elective surgery afterwards. But it's quite useful for good surgery. So this is more the first line, the sigmoidoscopy and rectal tubing, and then elective surgery. With fecal, it's more difficult. We have to go for laparoscopy. For colorectal cancer, this goes straight to surgery. And this is mostly for debulking in a lot of cases, because if patients are in complete obstruction, it's quite likely these patients are actually quite like late stage cancer. So it's debulking normally and for symptom relief. And what we can do for these patients is normally, if it's quite acute, it's normally going to be a Hartmann's procedure. So if it's going to be lower, it's going to be descending colon, it's going to be a Hartmann's procedure because it's quite difficult to anastomose these patients that are obstructed. And they're normally quite unwell as well. And for these patients with the diverticular disease with persistent obstruction, for diverticular disease, normally the treatment is slightly different. It's normally to do with giving patients the ability to pass like light stool easily. But if it's persistently obstructed and they've come in quite acutely, the patient needs to go to surgery and have a Hartmann's procedure as well. And then for the last one, if your patients have pelvic abscesses, we can just do a percutaneous or transrectal drainage. We don't need to go in for surgery for that. But normally the pelvic abscesses, you would have to give them a CT scan as well, because the source of the pelvic abscess is normally in a female, it can be to do with like ovarian cancer, or in males and females, it can be another kind of cancer. So a pelvic abscess is normally a sign that there's some kind of other pathology going on, because abscesses don't really just come about by themselves. So we would drain it and then look for the source of it. And then it's important to get gynecological input if it's for female pathology or endometriosis, something like that. Okay, time is it? So this is just a quick, you probably all know what Hartmann's procedure is, but this is just a quick diagram to show you what it is. So you take out basically the sigmoid, and then you close up the rectum, and then give yourself a colostomy. And this is normally done in the acute setting for obstructive bowel cancers or any kind of pathology in this area. It's often done when patients are quite ill. But if patients are quite well and it's more elective, it's less common to use Hartmann's procedure and just to do an anastomosis. There's better patient outcomes, it's better quality of life as well. Okay. I think it's probably a good place to, where are we? Yeah. Let's just do this last slide. It's just a quick slide about colorectal cancer. There's more stuff later on about pathology and cellular stuff and like elective parts, but this was only really the acute setting of nausea and vomiting, so we can discuss that another time. I think this is a really important thing to remember, especially I know you said the OSCEs are really far away for you now, but screening program is really important. So for patients, normally they get endoscopy at 55, but this kind of, unfortunately, this kind of depends on like local guidance, but it's normally 55 where patients are given endoscopy. And then from 60 to 40, patients are given these fecal occult blood tests every 2 years. But then after 75, patients can request a kit up to every 2 years. So you kind of have the peak age is 60 to 74 for patients with colorectal cancer, which is why they get a test every 2 years. Okay. Does anyone have any questions about what we talked about today? I didn't have time this week to do a quiz, but I'll do a catch-up quiz when we do another one. Are there also any other particular parts of surgery you want to go through? Because I know it's quite like a massive topic. If anyone has a particular interest or anything they want to go over. Oh, urology. Okay. Mm-hmm. Vascular or breast, yeah. Anything you think that comes up a lot? Yeah, I was kind of thinking that's why I did a lot of general surgery to begin with, because I think the people that set the most exams at Liverpool are general surgeons, because most of the stuff that comes up is general surgery, really. You might get one question about vascular, maybe one or two of urology. I think it's just so, general surgery is just so vast, quite something to cover quite well. And they set quite a lot of questions in it. Breast, yeah, I could do breast. There's not too much in the curriculum about breast, but it might be one lecture's worth if people are interested in it. Any questions about nausea and vomiting or anything that we discussed in the treatment plans, things like that? I always get the treatment plans from NICE and from local guidance. So when I put this in the shared thing for paramedics, you can use all these for your exams because they're foolproof, really. Are you all enjoying the Zoom teaching? Do you think there's enough per week? Yeah. What was this, Emily? Sorry. What's about? Oh yeah. So the vomiting, electrolyte, and abnormality that comes up. Yeah. So this normally comes up for the electrolyte abnormality normally comes up for pyloric stenosis, doesn't it? So this commonly comes up in OSCEs and it will come up in exams most commonly, but it's normally related to pyloric stenosis, but it applies to everything. So frequent vomiting. So you get low potassium, and low chloride. So it's hypochlorite acidosis. So you get an acidosis, and this is because you lose a lot of stomach acid with when you lose hydrochloric acid, and because of the potassium exchange to give yourself more chlorine, you lose a lot of potassium as well. So it's low potassium, low chloride acidosis, which is what the abnormality is, if that makes sense. Okay. Yeah, the coffee bean sign, there's quite a few signs actually for volvulus. Just radiopedia, really good. So there's a coffee bean sign, which is the most common, is probably the one you'd be given in an exam because it's quite common. Acidosis, yeah, acidosis. Let me check myself. Yeah, I'm pretty sure it's acidosis. Okay, right, let me check. Sorry, how close? Yeah, of course it's alkalosis, yeah, because you're in HCl, yeah. So yeah, could you emit HCl, you vomit it out, which causes an alkalosis. So you get low potassium, low hydrochloric acid, which gives you an alkalosis, yeah. And you get high bicarbonate as well. God, teaching me now. Yeah, catching for other signs, radiopedia is really good, but it's more, you're going to get one basically, so you might as well give them all a good look over. Yeah, that's it. I've got the feedback form, which is in the chat now. If everyone just gives it a quick go over, and then if there's anything you particularly want on the feedback, pop it in. And if you need anything else, you can always message me as well. Okay, thanks.